Thank you, Habib, and thank you to all of you for your interest and for being here. It's a pleasure for me to speak about this topic. We today are going to highlight some comparisons of vestibular migraine with other vestibular disorders so that we can facilitate our ability to efficiently diagnose and triage these patients to a productive treatment strategy. But in order to do that, we have to become familiar with details about migraine pathophysiology of which we may not be aware. We also, to take this a step further, need to be familiar with migraine therapies, which generally are not in our curriculum. We're going to have time for questions, and we're going to talk about treatment of vestibular migraine as well. I love this quote, and there can be few physicians so dedicated to their art that they do not experience a slight decline in spirits on learning the patient's complaint is of dizziness, usually when you're running about an hour behind. But it's a pleasure to be in a room full of people whose spirits don't decline, because vestibular disorders is what we are interested in, what we find challenging, and we know that we have insights that can allow us to advocate effectively for our patients. Vestibular disorders are extraordinarily common, but they're also very confusing. Most of what we learned when we were trained, even if we were trained recently, is now no longer applicable. Habib, Dr. Rizk, and others conducted a survey questionnaire through the Vestibular Disorders Association, which demonstrated a broad variety of vestibular disorders, and vestibular migraine was the most prevalent. What was really stood out is about 2/3 of patients had multiple vestibular diagnoses. Many of them had disability, not meaning that they are in a wheelchair or couldn't work, but they can't do the things that they want to do, need to do, say they're going to do. In effect, they're not reliable anymore, and often in the peak, most productive decades of their lives. The other thing that was astonishing in this survey is the number of providers that these individuals had seen in their vestibular journeys. So we clearly, by being able to recognize and triage and treat patients effectively, can more efficiently make these patients better before their symptoms become long-lasting, plastically entrained in the central nervous system, and durable to treatment. Another reason that vestibular disorders are so confusing is that if you look at this correlation from this survey of diagnoses on the top and the symptoms that patients report on the bottom, almost every vestibular disorder reports every variety of symptom. So it can be a real muddle. What we want to do is just recognize patterns. We, as Dr. Staub said, we have been trained ourselves with experience so that we know what we want to do, and we don't have to consciously think and puzzle out every step that we take or every movement that we make. Instead, we don't want to empirically diagnose every motion as if we were doing it for the first time, or diagnosing a patient as if it was being done for the first time. We want to recognize what we see. And one of the features that is not talked about enough, I think, is the time course of vestibular disorders. This is a key to establishing a correct diagnosis in very many cases. When we talk to patients with vestibular disease, this is often what it looks like. This is what we would like it to look like. But what it instead, we'd love to say, hey, I know what you have. I can extract this information from this tangle of data that you're giving me. Instead, this is often the way we feel if we're not prepared. And then we kick the can down the road. We look at our watch. an hour behind. We're going to get some vestibular testing, and I'm going to see you back. And that just gets into a deeper and deeper problem, because then they think the answer is in the vestibular testing. The day after the test, they call you to find out the result, and you have to explain to them that that's just another bit of data to put together, and you're going to put it all together when they're back in the office. So let's think about the time course. I think we're all familiar with vestibular neuritis, a patient who has a vestibular crisis and who is incapacitated, often ends up in the emergency room or in the hospital with nausea and vomiting. They have a drop in their symptom intensity over the first days of their crisis, and when the cerebellar clamp creates an artificial vestibular tone in the vestibular nuclei to decrease the differential firing rate in the two vestibular nuclei, and then they have and they recover, but they don't feel right, and it may take weeks for recovery to continue with the proper PT and movement therapy, so they can reprogram their VOR, and then they go on their way. And usually this is a one-and-done sort of phenomenon. That's vestibular neuritis, and we recognize that pattern when we speak to patients. Now, then we have patients with BPPV. They may have a low-grade chronic disequilibrium, but the intense, very brief episodes that happen mostly when they're lying down and rolling over in bed at night are very recognizable. We also know that many patients do get dizzy when they first stand up in the morning or from a chair, but very few people get dizzy when their head first hits the pillow, and unless they do have otolith disease. And this tends to run its course with decreasing symptom intensity and usually frequency until it peters out within 2 to 3 weeks. This is just the natural history of the disease. Of course, if the superior vestibular nerve is involved in a vestibular neuritis or a vestibular injury, that superior vestibular nerve also innervates the macula of the utricle, and it may actually have, so you may have secondary BPPV from the release of otoliths, and that so you have a combined curve of a vestibular neuritis that may be stretched out longer than usual because the additional BPPV compromises the ability of the central nervous system to clearly see the vestibular injury and to compensate for it. And then, of course, even though the VOR gets corrected, the utricle may remain injured, and the patient may be susceptible to recurrent bouts of BPPV. This is another pattern to become familiar with. And then we have patients with Meniere's disease. Now, some of the BPPV patients will be able to tell you which is the ear involved. None of the vestibular neuritis patients will. But the patients who really have Meniere's disease will say, when you ask them, is there any reason that you would know which ear your events are coming from? Well, the patients with Meniere's disease can usually say, well, yes, I know the ear. This is the ear that bothers me, and that bothers them because they have fullness, they have tinnitus, they have fluctuations in hearing. They have incapacitating attacks that are regularly irregular. They are so irregular that patients become superstitious about the things that may cause them. Because they had an attack that happened when they were unloading the dishwasher. They haven't done any dishes at home for 3 years, and they are riding on their convenient laurels with that. They may go through periods where they have low-grade symptoms, where they don't quite feel right because of a period when there's a slight irritative fullness on one side and a vestibular imbalance. They'll go through periods where they do have head motion sensitivity. Now we have patients who have PPPD. They have symptoms all the time. They have good days and they have bad days. They may have exacerbation with certain activities or environments, but they are almost never completely symptom-free. This is another pattern that we recognize, in addition to the other signaling you get from these patients about coexisting anxiety and their inordinate amount of incapacitation with their symptoms. And of course, these patients often, they started out with a real vestibular event, something that maybe you recognized. It could have been a BPPV or a unilateral vestibular loss of a neuritis, but they were one of those who never recovered and are in this pattern. When we think about vestibular migraine, well, we have to consider every one of these patterns. So a patient with vestibular migraine, well, what is the time course of vestibular migraine? Well, we don't know. So I just made a big point about recognizing the time course of disease, which is practically useless in identifying vestibular migraine patients. We have to recognize it a different way. And that different way is to recognize a pattern of vestibular migraine that is not related to the time course. We don't recognize it because migraine itself is not in the otolaryngology curriculum. As far as I know, it's not in the PT curriculum or the audiology curriculum. It is, migraine is considered the neurological disease, and is neurology is considered the specialty care provider for migraine. So we need to become familiar with migraine pathophysiology in order to understand what migraine looks like when it is sitting right in front of us. So let's talk about that. Migraine is extraordinarily prevalent. People say, oh, that's something you get when you're young and then it goes away. Well, that's not true if you're treating vestibular migraine. In fact, it starts in infancy. Who knows the very first sign, clinical manifestation of migraine? It is colic in infants. An infant with colic has a 78% chance of having migraine with aura by age 8. And then in early childhood, there is a tendency to have GI disorders rather than headache itself. A child with stomach aches doesn't get a stomach ache because the brownie is irritating the lining of the stomach. They get a stomach ache because the xanthines in the chocolate of the brownie get into the brain and trigger a migraine, which doesn't cause pain in their case, but they get a strong parasympathetic outflow, which causes gastroparesis and a stomach ache. We also have migraine in the elderly. There's an obvious female to male preponderance, with about a third of females in the most productive years experiencing attacks. Now, migraine itself is extraordinarily undertreated. And I don't have slides here for migraine with and without aura that list the criteria. Why? Because in general, they've been a little destructive. It's too easy for us in medical school to study these criteria, which we're presented with, to be tested on them. We have, in effect, become mentally gated to these criteria and are too prone to use them as an exclusion criteria for treating patients. These are rigorous, and they're designed as inclusion criteria for epidemiologic and drug efficacy studies. So if you're doing a drug efficacy study on vestibular migraine or an epidemiologic study, raise your hand. Well, nobody. So, but there are very many patients who will respond to treatment, who have vestibular migraine, who will respond to treatment nonetheless. You just wouldn't be able to include those patients in these studies when you're doing them. Now, even patients who have really obvious migraine who do meet the criteria, that's migraine headache, only about 50% of them are diagnosed, and only about 15% of total are even satisfactorily treated. Many of them, they say, well, I still get headaches and I'm still disabled, or the medicines do take away the pain, but I get disabled in a new way when I take my rescue medication. So the point is that most of the patients will not meet criteria, but they will respond to and benefit from treatment. So in otolaryngology, the presentations of migraine we want to talk about are today vestibular migraine, but sinus headache and facial pressure and atypical facial pain are very, very prominent. And when I say these are prominent, like think about sinus pressure. Everybody has sinus headache. Well, if I took 100 patients off the street with self-diagnosed sinus headache, and we did CAT scans and did physical exams and endoscopy on all of them, out of 100, how many do you think would have chronic rhinosinusitis accounting for their symptoms? 3%. 3. All of the rest would have recognizable and classifiable headache disorders. This is an example of migraine, not because it doesn't manifest in the head, it manifests in the face. V2 is involved more than V1. We don't recognize it. And this is where we need to shake up our thinking about vestibular migraine as well. Patients have oral pressure, otalgia that doesn't respond to any treatment and for which a cause cannot be identified, hyperacusis, which is actually a cardinal symptom in the IHS migraine. But we're also seeing patients who have recurrent BPPV and sudden hearing loss, Meniere's syndrome, and even tinnitus, who have migraine, and for whom migraine is a very strong modifying factor. So what is migraine anyway? It's a headache with other neurologic symptoms, a headache with, but it is very highly variable. And what is really interesting is that the cardinal symptom of headache need not be present. So we only think about migraine headache. We don't think about migraine as a disease, of which headache is one of the manifestations. We're interested in migraine that is for which vestibular symptoms are manifestations, and that is what vestibular migraine is. Migraine headache itself is very, very prevalent. We have about a 13% prevalence in the US. And so if you look at any 4 houses in a row, there's usually one person in those 4 houses that has migraine. In any group of 5 women, 16 men, or 11 children, there's going to be one migrainier in there. Worldwide, this is a summary of the epidemiologic studies done on migraine. Worldwide, we're at 11% prevalence of migraine. So over 1 billion migraine headache sufferers, a big problem, a very common problem. Now, most of what we know about migraine pathophysiology is recent. Migraine was the champion topic of Harold Wolff, a neurology professor in Harvard, who promoted the vascular features of migraine because of the pounding nature of the headache. He was convinced after drinking huge amounts of caffeine to provoke headaches himself and making his residents do the same, that there were aura symptoms that were caused by oligemia and vasoconstriction, and that were followed by painful throbbing that was caused by vasodilation. And this is such a simple and sexy idea that it caught on. It caught on in almost a blinding way. And some people believe he probably held up our insight growth in migraine for about 30 years because of it, because these notions are just simply incorrect. But most of us, that's what we think about with migraine. The new evidence it can be summarized in 4 different points. One is spreading neuronal depression that happens on the surface of the brain as a phenomena. And a second is trigeminovascular efferent activity, which is a complicated way of saying that there are efferent nerve endings that secrete toxic peptides around the blood vessels in the head. Brainstem nuclear changes, in which various patterns of nuclei in the brainstem become sensitized or hypermetabolic or function at altered states than are normally physiologic. And finally, frank hypersensitization of nuclei, which are associated with convergence of sensory signals that amplifies them. So we're going to go through these one by one. Visual auras. Who here has had a visual aura? Yeah, it's a common phenomenon. Well, Robert Lashley is a physiatrist. He was in Boston in the 1940s, and he famously drew his own visual scotoma. Now, the visual auras have about 9 different visual patterns, but this is one of the most common, a paracentric zigzag lines of patterns of light and dark lines that expand eccentrically and laterally from the fovea outward. And he hypothesized that there must be some electrical disturbance that's happening and propagating across the cortex of the brain at 4 to 6 millimeters per minute. And that was really an incredible clinical insight, really impressive. Across town, Aristides Leal, a Brazilian graduate student in the laboratory of Hollowell Davis, who is the godfather of auditory physiology in Boston and who later went to Wash U, was working on an epilepsy project and recorded this wave of spreading depression, which he showed to his mentor, and he was told it was an artifact and that he should forget about it, but he didn't. He published it. But it wasn't for decades that these two were, that the one was seen to be the explanation for the other. In fact, the phenomena now carries the name spreading depression of Leal. This patient with exercise-induced migraine got off of the basketball court and went into the functional scanner and had his visual aura. And you can see in the visual cortex this spreading a wave of depression in red, excitation in red, followed by the depression in yellow across his visual cortex. And this was what was happening over 18 minutes in his brain. Now, this is what we think about with aura, visual. This can happen on any part of the surface, any portion of the cortex of the brain. You can just imagine the variability of symptoms which could originate depending on the part of the cortex which is involved. So some people have dysarthria, or they have aphasia. I have one patient who, when she's going to have an episode, she knows she can't speak. She can't tell her husband that she's about to be incapacitated. So her signal is she marches in a circle, and he knows that she's going to go lie down, take her medicine, and be incapacitated for a few hours and take a nap. Now, we think about this, these vascular changes, and cerebral perfusion studies do show these really impressive changes with vasoconstriction followed by vasodilation during a classic migraine headache episode. And you can see that the aura symptoms do indeed occur during this period of oligemia. But the headache starts during the vasoconstriction. In fact, the headache ends during the maximal vasodilation. So this is not a very good explanation for what is causing the pain. What is causing the pain? Well, what it is that all of the intracranial vessels are innervated by branches of V1, the first division of the trigeminal nerve. And these unmyelinated C fibers secrete a cloud of toxic substances called inflammatory neuropeptides, substance P, neuropeptide Y, and importantly, CGRP, which has been the target of a lot of pharmacologic remedies for migraine that are new. Well, this is what sensitizes the pulsing blood vessels and accounts for the throbbing pain of a migraine episode. When we do awake surgical experiments, we we know that the brain itself is insensate, but touching blood vessels and dural venous sinuses in the head results in referred pain outside of the head. The supratentorial vessels radiate to this frontoparietal a pattern which is classically associated with a migraine headache. And the posterior fossa and tentorial vessels can result in this pattern in the occiput, running down the back of the neck, or even a helmet-like distribution of referred pain. So the pain isn't happening to these vessels on the outside, it's happening intracranially and can be referred out. We also have brainstem nuclear changes. Now, brainstem nuclei these are ancient. These are the old nervous system before the neocortex. They control our levels of alertness, our mood, our fight and flight, our autonomic reflexes. And it seems that patterns of hypermetabolism in the increased glucose metabolism in the brainstem can affect different nuclei and different patterns in different individuals and cause different symptoms. In fact, these are the origin for many patients of prodrome symptoms that come on hours before pain ever occurs. Perhaps the most important among these for us as otolaryngologists is the activity in the superior salivatory nucleus, because every migraine episode is associated with a strong parasympathetic outflow. That means for otolaryngologists, symptoms like rhinorrhea, nasal congestion, tearing, and edema that can be misinterpreted as allergy or non-allergic rhinitis, but never as migraine, because without migraine in our curriculum, we have sort of a perceptual blindness to migraine. We are going to, autonomic dysfunction of in migraine is not localized to the head and neck, though. It is a body-wide outflow. So although we do have local symptoms, we can have cardiac symptoms. Most patients with chronic migraine have really low blood pressure, for example. They have long QT intervals in their EKGs. They have GI symptoms like the children do, so many of them have decades of irritable bowel. And some of the cardiovascular symptoms are so profound that they get a syndrome known as POTS, paroxysmal orthostatic tachycardia syndrome. These are the teenagers who faint when they stand up. They can't go to school, and they all have lots of migraine headache. They usually see cardiologists who are giving them autonomic control drugs. They respond better to migraine management, effective migraine management, because this decreases the increased parasympathetic outflow. So when we think about this, there are just this is just redundant, but more, and if you know more and more about the autonomic nervous system, there are just a host of symptoms which can be explained by autonomic dysfunction related to migraine. Almost every specialty is involved. Finally, patients who have migraine are hypersensitive. They don't tolerate sensory stimuli, especially during a migraine episode. Characteristic of patients with migraine are the photophobia and phonophobia they experience. These are cardinal symptoms. One mechanism of this was explained by Remy Burstein, who is an anesthesiologist and a pain investigator, and he demonstrated that there's a convergence of dura-sensitive neurons and light-sensitive neurons that when we turn on, when we turn on the lights, we get an increased firing from the dura-sensitive neurons because of convergence amplification. This is a fundamental property of of neural physiology. So this can explain why patients with migraine are having pain with light or pain with head motion. Now, why do we get it? It does run in families. There is a form of migraine that is very easy to trace because the aura symptom of hemiplegia from, imagine cortical spreading depression that goes down your motor strip in the brain, causes a hemiplegia for 15 or 20 minutes, and then it goes away, and it's followed by an intense migraine pain episode. Well, it must be a new mutation because there's little survival value in getting hemiplegic at the beginning of a fight or flight episode. About half of these patients have a defect in a calcium channel, another quarter in a sodium channel, and others in a second messenger. It's easy to trace, but we think that this is a model for common migraine. The end result is that you have what's called a sensitive brain, or a brain that is susceptible to overloading and triggering, in a sense. Now, everyone is sending in their DNA to find out who their ancestors were, but that DNA is used in a lot of different ways, and we do see some ion channelopathies in that group in all of this collected data, but there are genes associated with many other processes indicating that this is a much more complicated convergence of susceptibilities than just ion channelopathies. If one of your parents has migraine, you're about 40% more likely than the 13 to have it, and both of them, you're almost sure to get migraine yourself. One really good demonstration of the lack of habituation in migraine is the use of passive oddball auditory potentials. So these are sound stimuli which are given in a train, and then there's an odd stimulus like a beep, 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 beep. Well, the first time you get that big beep, you measure the cortical response. That's the P300 response. And a patient who is a control patient hears it, and then they hear it again, but the cortical response to that is not as large, and it stays attenuated. This is habituation. In a patient who has migraine without aura, who is not having an attack, is just on a normal day, an interictal day, the second auditory oddball potential causes a greater cortical response, and the third response is even greater. And this, you can imagine, builds and can result over time, explains why patients who are migraineurs are in sensory environments that are very irritating to them, and they say, you know, I'll be fine if I get out of here now, but if I stay here in this environment, whether it's the smell, the sound, the light, or the motion, then I know I'm going to be incapacitated. The first domino of a physiologic cascade is going to fall over, and I'm just going to have to hold my mouth right and get through the consequences of it. So this explains a little bit the triggering of migraine. We tend to classify the triggers of migraine into three broad categories: dietary, environmental, and physiologic. The environmental triggers are common. Almost every sensory modality, odors, bright lights, especially computer, because the blue light is unusually provocative in the entire spectrum for migraineurs. Noise, excessive head motion or motion of the visual surround, weather, which we have no control over, and altitude are real susceptibilities and provocateurs for many patients. Physiologic triggers, anxiety and stress are at the number 1, and I would say also at the number 2 position. Fatigue and lack of sleep often precede an episode of migraine for individuals, and sometimes even oversleeping. People get fatigued at the end of the week, they get a migraine, they try to make up for it by sleeping 10 hours on Friday night, and then they get a migraine from sleeping for 10 hours. And they think it's the lights in Costco that is giving them the headache because they go there every Saturday. But it could be that, or the visual spatial environment in there as well. Hunger, exercise, dehydration, hormone changes, pain, especially any real pain that's feeding into C2 and above, feeds into the trigeminocervical complex, the confluence of the trigeminal nucleus and the nucleus, cervical nucleus of C1 and C2. So everything from the shoulders up, real pain can just activate the system in a migraineur. Travel is sort of a perfect storm for a migraineur. You have stress, the letdown of stress after getting to the airport and relaxing can bring on a migraine. For some altitude, alcohol, many people tend to drink more when they're traveling, which also leads to dehydration, as does altitude. And then the fatigue of time change, and if you're going to Disney World, you have one or two, every child you travel with is a multiplier on this wonderful cocktail. Now, food triggers, everybody thinks, well, if I had a food trigger, I would know it because I would eat it, I would get a headache or my dizziness an hour later. I think that the important thing to think about with triggers is that the word trigger makes us think of a gun and triggering or the popping of a balloon. Partial triggers is a more accurate way to think of it because triggers add up. Partial triggers add up in different ways on different days, and we can get away with our triggers all the time. And it's only when they add up and put us over a threshold, our genetically predetermined threshold, that we suffer an attack. So there are patients who have byproducts of food, aging, and fermentation. And we have other foods that have amines that are very similar to neurotransmitters. Like caffeine and nitrates, MSG, and the xanthines in chocolate. We don't scientifically understand why bananas or nuts or citrus affect us. The effects are not immediate. They can be if it's a strong trigger for a person, but sometimes a food trigger can raise your threshold partially for a few days. So you don't really understand what was the stack of triggers that led to an individual attack. And as I mentioned, we get away with our triggers all the time, but in the wrong combination, they put us over the top. Now, it's not food allergies in general that cause the migraine as triggers, but allergy may have something to do with it. We don't use IgG for foods clinically. No one will pay for it because there isn't enough evidence, but there was an excellent study with 266 foods tested for IgG, and there were crossover studies with provocation and elimination diets, and there was a definite increase in migraine activity and decrease in migraine activity when they were on the provocative and avoidance diets based on their IgG data. So basically, your genetics determines your susceptibility to migraine, and combinations of partial triggers add up to give us an event. This gray box represents our genetic inheritance, and then these are the combined dietary, physiologic, and environmental triggers, and we exceed the threshold. 2 events are shown here. And we're going to learn how we can, I think by the end of this, we'll have a good idea of how to bring that curve underneath the threshold line. So let's talk about migraine and vertigo. Here's a patient, a typical one. A 70-year-old man presents with a 30-year history of dizziness and episodic vertigo. Some of his vertigo attacks were clearly positional. Others, spontaneous and lasting for hours. These were not associated with changes in his hearing, but he did report left aural fullness, a bobblehead rocking sensation, photophobia, and nausea with the attacks. Symptoms progressed to a constant disequilibrium. He has a family history of migraine and dizziness, which occurred in his mother and his sister and in all 3 of his children. His audiogram was normal through 4K, then a right greater than left downsloping sensory loss, and ENG was normal and the MRI was normal. This gentleman had symptoms which resolved on a minuscule dose of nortriptyline, 20 milligrams. Nortriptyline was an early antidepressant that was horrible because in the 60s there weren't other alternatives, and to get the mood-altering effects from this medication, high doses were necessary, and at high doses there were far too many side effects. But at 20 milligram, at very low doses, it's very tolerable and is quite good at preventing migraine activity or stabilizing the head. So is his dizziness central or peripheral? This is the way that we always were taught to think. Let's just forget about that because it may be both. And more and more we have to think about things. We have always thought about it from the ear and maybe that other mysterious place on the inside. And we just learned this morning just how mysterious that and complicated that labyrinth is. You can get lost there, and it is dizzying, I must say. So let's just break this down and think about vestibular symptoms in migraine and from where they may arise. At the cortex, maybe in the thalamus, in the limbic system, basically I would call this category thalamus and up, and it's a big category. And then the infratentorial, the cerebellum and the brainstem nuclei, that's what we used to think about as central dizziness. And then in the inner ear as well, even in migraine, the inner ear, really? I know you think I'm kind of a fanatic about this, but I'm gonna, I think, back up this notion that migraine and the inner ear can be co-involved. Now, this is just one little glimpse of how of cortical expression. We saw this morning how broadly distributed the cortical system in vestibular processing is. On the right, this is just a pattern from a saccadic eye movement. But there is one place that was identified, the parietal opercular area, OP2, that seems to be pretty consistently stimulated with vestibular stimulation. And this may be the actual vestibular cortex in the posterior insula. Now, just imagine cortical spreading depression, that spreading depression of Leao, that moving over other areas of the brain. It can be almost anywhere and have an effect on your vestibular sensorium and processing. And it can be very vague and difficult for patients to describe, and even for you to make incisive inquiries about. But that's a possibility. And I do have a couple of patients who have vertigo as an aura symptom to a classic headache. That's their pattern, just as the hemiplegic migraine patients have hemiplegia. They have a localized and repeatable aura. Now, there are other places that vestibular information resonates with the cortex in different ways that changes our relationship either in many different ways. It can change our position in our map in space. It can change our perception of scale. It can change our perception of the support surface that we're walking on. The thalamus is the great relay station to which neural inputs feed and then become distributed for coordination among multiple cortical areas. And we couldn't have had a better demonstration of that than we heard before lunch. So when patients talk to us about I think the best way that they relate to, I asked them, do you ever feel like you're sitting right here, but you feel like you're back here when you're looking at the room from another position? And they go, yes, yeah, I never really could describe it that way. They feel so validated to have someone who might partially understand their symptom. So this is displacement in space. Some patients can feel that the floor is tilted underneath them. And so how about PPPD? Well, it may be that there is a kind of a resonance that exists between the thalamus and areas in the parahippocampus where we store a lot of information about our position in space. That's where remember, that's where the Google map is. And if it is, if that map is distorted, then unfortunately, and we focus too much on it, we can really mess it up, especially if we bring in the hyperactive autonomic roommate. In getting the autonomic nervous system involved, just spoils everything. It's just like a really, really toxic house guest. So, but this is sort of what happens in chronic pain. Because then it's really hard to shake. And in patients with tinnitus, they're just like the patients with unilateral vestibular loss. Not all of them get PPPD, but some do. And the patients with tinnitus, not everybody with hearing loss gets tinnitus, some do. And this is sort of what happens to them too. The parahippocampus becomes involved, and then the autonomic nervous system. I recently had a patient who had intractable essential tremor, which got to the point that he was having difficulty operating a spoon. This is life-threatening, of course, and focused ultrasound was used to lesion the ventral intermediate nucleus of the thalamus, which was really successful on one side, but they missed on the other side. And next to that ventral intermediate nucleus is a vestibular processing center, and he had has a permanent tilt of about 12 degrees to one side. He just feels like he can't even cognitively override the fact that he just has to believe it's not there and operate his legs in a different way. So this is the kind of distortion that can happen when the thalamus itself is injured. Now, there are other possible central mechanisms. We know from functional imaging that we can predict with 100% accuracy the side of a migraine episode because of the increased metabolic activity in the dorsolateral pons. That's where the trigeminal nucleus is. Well, other nuclei may also be involved, as I mentioned, but what if the vestibular nuclei happen to be involved in that pattern? All of those other nuclei I talked about, they have a synergy. They get back and forth feedback with the vestibular nuclei, and so they can be affected and also even ramp up this hypersensitization, or I think it's better just to call it a dysfunction. Because I think that it's not so much that it's hypersensitive, it's just very, very sensitive to disturbance and very annoyable. So if the vestibular nuclei are involved, perhaps disequilibrium, head motion intolerance, visual motion intolerance may result, and even frank vertigo. And a lot of these patients will tell you when they come in that I took meclizine, which is an anticholinergic vestibular suppressant, and it was not helpful. Well, the anticholinergic vestibular suppressants act primarily on the afferents from the semicircular canals, which are cholinergic. But patients who have abnormalities in the central nervous system, they don't respond as well. So only about 20% of vestibular migraine patients respond with decreased symptom intensity to meclizine. And this is a tell when they come in. When we examine patients with vestibular migraine, their absolute perceptual thresholds for rotation in the semicircular canals are the same as normals. So are the tilt sensitivity from the otolith organs. But as we learned, the otolith organs cannot tell the difference between tilting and acceleration. The way they tell the difference is an integration, evolutionarily the way we learn the difference is that we later on got semicircular canals. The combination of canal input and otolith input allows us to tell the difference between acceleration, in which it's a pure otolith organ stimulation, with nothing from the semicircular canals, or a combined stimulation. Well, so there's a stimulation that's very difficult to replicate in the lab, and Richard Lewis persevered and did it, called roll tilt, where patients are strapped into a chair and they're rolled and tilted in total darkness. You strap them so well you try to prevent them from feeling somatosensory clues about the direction of their motion. And the patients with vestibular migraine have extraordinary ability to tell when that process of integration is not working. So that points to the brainstem and the interaction between the cerebellar vermis and the vestibular nuclei. Patients with vestibular migraine can't stand stimuli like this, and that will stop in just a motion, just in case anyone here is sensitive to it. But this is an important part. Optokinetic nystagmus is an important part of our vestibular processing. The drift of a visual scene is actually a surrogate for canal stimulation, even after the cupola has come to rest. It results in a perceived motion. So a lot of times the patients will tell us that, you know what really drives them crazy is when they stop at a traffic light and the car or bus next to them starts to move and they think they're drifting backwards and they jam on the brake harder. It happens to everybody, but it happens a lot to these patients. So, and they're very averse to any similar optokinetic stimulation in real life. And of course, they're very susceptible to motion sickness. Almost every one of these patients who get vestibular migraine later in life remembers being sick in the back seat of the car as a kid. And motion sensitivity is really interesting because it's a novel stimulus that we did not evolve with. You know, we evolved with gravity. We did not evolve with the complex motions that come with trains and automobiles and planes, and virtual reality goggles, which mess people up because they make you perceive distance by changing scale of images, and there's no vergence change, which is usually a part of the natural solution for calculating the distance from an object, and so patients get crazily intolerant. And then these things, this activates a lot of autonomic symptoms in these patients. Now, how about the inner ear? Well, there is a possible inner ear mechanism, and Zoltan Vass and Fred Nuttall's lab in Oregon demonstrated that the inner ear itself is innervated with trigeminal fibers from V1, the ophthalmic division of the trigeminal nerve. And by electrically stimulating V1, he produced not subtle but profound changes in the vasculature in the inner ear, so profound that there was transmural extravasation of protein in the spiral medullary artery. So you can imagine if this is happening throughout the labyrinth, the kind of disturbances that could occur. You can even stimulate V1 in migraineurs and provoke an ipsilateral irritative nystagmus. So, and that simulates a release of inflammatory peptides. There's a latency of about 25 seconds. It takes about 120 seconds for the response to attenuate. It's visually suppressed. There is a linear slow phase, which comes from the labyrinth, not a logarithmic slow phase, which we would expect if this were a central process. And it's an ipsilateral effect. So this is a common problem. I think this Venn diagram, which demonstrates how big a problem vestibular migraine is. A lot of these patients also have benign positional vertigo, and some of them have Meniere's disease. Meniere's disease really exists. It is so common, migraine, if migraine is 13% of the population, that's the IHS migraine. Now, how big do you think all the patients who have migraine, even the ones who don't meet criteria. Nobody really knows how big it is, but I think that the migraineurs, the IHS migraineurs, are sort of the tip of the iceberg. But 25% of the IHS migraineurs will report attacks of vertigo at some point. So migraine-associated vertigo, vestibular migraine, is very common. When I started my career, 60 years ago, everything was Meniere's disease, and we were listening to patients, and what we listened for is if they said they had ear fullness, you just have a low degree of hydrops. You don't have Meniere's disease yet, but it could be hydrops, and we better treat you now so it doesn't develop into hydrops. And now we just have a different way of looking at it with new eyes. So we should be seeing 10 to 20 vestibular migraine patients for every one Meniere's disease patient in our clinics. So patients with some really key pearls for identifying these patients with vestibular migraine are these unusual symptoms like rocking. Now, I am not convinced that a unilateral vestibular lesion, even of the otolith organs, can cause a chronic rocking vertigo. And if there is a way for that to happen, I guess I need to learn, and maybe it does happen, but it seems to me most of these patients have more of a central vestibular syndrome. Floating, displaced in space, swaying, these are not symptoms generally created in the inner ear. These are symptoms created by errors of vestibular processing. So these are key words that we listen for when we listen to our patients. The motion sensitivity we talked about is extremely common. This idea that there is a threshold for triggering attacks is unique among patients who have vestibular migraine. Almost no one else, except for maybe a BPPV patient who has a threshold for a particular position that provokes attacks, could be argued, but this is clearly different. And the symptoms are really variable in duration. And in fact, it may be that a patient has, it can be all over the map. I can't say that there is a single time course, as I mentioned before. As I mentioned, there were frequent reports of visual vertigo, grocery aisles are a problem, and then this issue with stopping and starting the car next to other and other cars and vehicles, driving through the shadows of the trees on the road drives them crazy, or past a picket fence with a fluttering stimulation in their visual field is a problem. Intolerance of movement of the head and visual surround is really frequent, and sometimes you'll do the Hallpike testing, you won't see any vertigo, but they report symptoms not from the position, but from the movement from position to position, from assuming the Hallpike position, from sitting back up, from turning the head to the other side. And it can be hard to sometimes to be sure that otolith disease isn't also present. But sometimes patients will tell you that they did have these big attacks, and they say, I went through this horrible episode, and it was about 4 days, and it sounds like a vestibular neuronitis, but something is missing. They don't have this long period of compensation afterward. There's no tail. So they were like fine when the episode was finally over, completely reset. So this is something to watch for as well in this group of patients. Now, when we do position testing, if a patient is symptomatic, they almost always have some degree of positional vertigo, but it doesn't usually follow the rules for otolith disease. Occasionally, we'll see someone who has a floating cupola, which Dr. Rizek mentioned this morning, because we theoretically, release of inflammatory mediators in the inner ear can increase the endolymph density sufficiently that the cupola floats in the dense endolymph and causes a paradoxical agiotropic response in the lateral canal. And but you may see the patient a few weeks later when they're symptom-free and they have none of that positional nystagmus. So is headache always present? They only about half the time in some of their episodes of vertigo. And often the patient has a prior history of migraine headaches, but they think that they've resolved. Often you'll talk to them and you'll say, well, how many days in the last month have you had a headache? And they'll tell you 3 or 4. And then you say, well, how many days, and how bad are they? And they says, oh, they're still pretty bad. And you say, well, how many days do you have any headache? Even a mild headache, because that also counts. And they say, well, that's just about every day. And so their headaches, or they'll say, well, where do you feel your severe headaches? I says, I get them right here and down the back. And then how about your mild headaches? Where do you feel those? He says, well, I feel them about right there and down the back. So you're having migraine headache, it's just not turned up to 11. A family history is really helpful. Now, we can get vestibular testing, but it's not always going to show us answers. But it is important because patients, can have vestibular weaknesses. You can get injury in the inner ear, I think. And if you have an injury, you have to go through a period of compensation. And so patients with vestibular migraine may go through periods with impaired and prolonged compensation for a routine vestibular injury, but they're not, because they're not good at compensating. Sometimes you'll see in a young patient that there is saccade deterioration at, or sinusoidal tracking that we usually see in a patient who's usually older than 65, but this is a 35-year-old woman and who seems otherwise healthy. They can't tolerate OPK very well. I think that often they'll refuse additional calorics, so it's not that they have a caloric weakness, is that you didn't get enough data to know that they have a caloric weakness, and you would depend on the VHIT because they refused all the other testing. And then the most important thing is only the patients with vestibular migraine have the VNG disturb them so much that they go home and they're incapacitated the rest of the day. That's actually an important part of the vestibular test. Does it respond to treatment? Yeah. Tony Mikulik and Dennis Poe demonstrated pretty early on that even with a pretty simple regimen of using just 3 things, caffeine restriction, topiramate, and nortriptyline, you can get about a clinical response in about 75% of patients. And rocking dizziness is something that is highly associated with migraine. Mulder-DeBarkmal syndrome is probably an overlapping form of this. Most patients with Mulder-DeBarkmal have some migraine as a comorbidity. There is a kind of this unusual optokinetic retraining that is poorly understood and not a reliable treatment for a lot of patients. I think about 20% of the people who I personally have sent to have that training have found it useful and in their recovery. It's hard to know whether that was really the key or whether their symptoms slowly improved anyway. But often it will help, we can help with some concurrent migraine management. So how about Meniere's disease? Migraine and Meniere's disease have a long history together. Think about this plasma extravasation that happens in the inner ear. We know that Meniere's disease, in a sense, is a kind of swelling in the inner ear. Any part of the body that gets injured, it'll swell. My thumb, I can hit it with a hammer, I can burn it, I can stick a pin in it, I can suck on it for too much, and then it'll swell. And the inner ear seems to get Meniere's disease when it gets injured too much by almost any mechanism. So we call Meniere's disease that's idiopathic, and it's Meniere's syndrome when we know what the provocative event was. And so it may be that migraine with these rather impressive vascular change and the release of inflammatory mediators may come and go in the brain, but actually injure the delicate inner ear. So is it possible that endolymphatic hydrox could result? There are lots of similarities, like the dietary triggers and environmental triggers. There's an excitatory followed by an inhibitory phase of the nystagmus. The excitatory phase is very brief. We rarely get to witness it in Meniere's patients. So imagine the cerebral blood flow study. Imagine the inflammatory mediators are coming out, diffusing, causing vascular changes, vasodilation, and then back to normal. And if that happens enough, could we get endolymphatic eye drops? Well, we don't know. But we do know that the lifetime prevalence of migraine in patients with Meniere's disease is not 13%, it's 56%, compared to about 25% in controls. And that patients with Meniere's disease who, when they have attacks, they are accompanied by at least one migraine symptom in about half of individuals. Is that a coincidence? I don't think so. I think that it may be that Meniere's disease for many patients is a complication of migraine. In fact, I treat my patients with Meniere's disease and with migraine management. The result is that I see as much of Meniere's disease as anyone. I do a gentamicin labyrinthectomy about 2 times a year. That's not very much. So we avoid destructive procedures. We stop a process of injury that preserves hearing, and the patient benefits from not having migraine headaches. So here is the spectrum of disease. Vestibular migraine on the left, Meniere's disease on the right. Well, many patients fall someplace in this zone. And if both are present, we treat both. So you can treat the inner ear with steroids, with injected steroids, I use fludrocortisone, actually, a mineralocorticoid for these patients. It's a steroid that they can safely take long term, but we manage the vestibular migraine component, or the provocative migraine, as well. So if anyone feels like you need to stand up and stretch for just 1 second, just to get your blood moving, this is the challenge of a long after lunch lecture. I'm a big fan. Just stand up for 5 seconds and move your knees. I'm in a better position to scan the audience than you are. So I think that we all need a little stand up here. We're here in this beautiful city on a sunny day, hiding from the sun. We can peek at the little sunlight coming through the shades, and I'll continue. Good. So anyway, when either part coexists, I treat both. And I certainly would address migraine before I moved on to any ablative therapy for Meniere's disease. And you know what? It's really interesting. I went back, and Prosper Meniere himself made a very important observation. If it is incontestable that individuals who are prey to vertigo, syncope, and vomiting have at the same time head noises and rapidly become deaf, is it not less certain that cerebral states called migraine give place in the end to similar attacks, and the deafness which arises in these circumstances would seem to us inevitably to be related to a disease of the same nature? How could it have taken us 150 years to come back around to this initial clinical observation? I think that Prosper Meniere was more insightful than even he was given credit for. So let's move on to BPPV. This is when people think that I'm really a fanatic. They say, oh my God. Then he's going to tell us about head and neck cancer and migraine. But it is interesting. Migraine, there is also a coincidence of migraine and BPPV. Migraine is 3 times more frequent in idiopathic BPPV than in BPPV secondary to head trauma or surgery. It is 2 times more prevalent in patients with BPPV than in age and sex match controls. And if you have migraine, you're 7.5 times more likely to get BPPV. It also affects females twice as often as males. I think most people are never really aware of that because it's so prevalent. We see a lot of both. There was a great study from Boys Town, which looked at 1,300 BPPV patients, and you can see the female to male prevalence and how that peaks during menopause. It's really big during puberty, but the numbers are so small it may not be significant. But when we look at the recurrent BPPV cases, there's a huge prevalence of 3.2 female to male during menopause. Well, can migraine cause BPPV? It may be that the same plasma extravasation injures the utricle enough that otoconia can shed, that maybe perhaps the utricle can become susceptible to increased shedding. You know, the natural history of BPPV is, many people get it one time and they never get it again. But if you have a patient who has symptoms that come back despite treatment again and again and again for a year, what's going on? Or you fix them, you never even get them completely better. It's because they're shedding new otoliths all the time. And they're not necessarily avoiders who are secretly sleeping in the recliner and they won't admit it to you. Recurrent BPPV, we all have these patients, responds to migraine management. And so this was a patient, I turned off the audio because it just runs a little too long, but she has had symptoms for years. She's been repositioned. She has chronic fullness in the right ear, but normal hearing, and recurrent episodes for years that get fixed about every 3 months with a repositioning by her physical therapist. But her episodes start again on the day of a migraine episode. And in fact, the Boys Town study for recurrent BPPV showed that about 1/3 of patients had their episodes start on the day of a migraine headache episode. And we treated her with nortriptyline, and her ear fullness went away. Her recurrent episodes of BPPV also went away. And so did her headache. So she was very happy about it. So this was 500 consecutive patients from my clinic, and we have vestibular migraineurs and BPPV and migraine patients. And you can see the overlap among the vestibular migraine patients. 22% also had BPPV. Among the BPPV patients, about 28% had migraine. This is much higher than the 13% prevalence in the population. And of the, remember the epidemiologic study done from or just the survey study from Vestibular Disorders Association, this included patients with diagnosis of PPPD, and you can see the overlap of diagnoses. So many of these patients have more than one process happening, something in the labyrinth and something in the central nervous system simultaneously. So there has always been, even without including dizziness, there was always a lot of symptom variability and even migraine headache. A lot of patients do get aura and pain, and they also get central symptoms. I made this slide a long time ago, and I put brainstem. Now it needs to be central nervous system. But other patients have have different combinations of symptoms. Some people have just the dysautonomia. So there is a tendency in migraine for patients to have less severe headaches over time. They still get like head fullness, but they don't consider that a headache compared to what they suffered in the past. So they tell you that their headaches have gone away, but that they actually have not. So we need to be aware that this process continues. So in a patient who has new onset dizziness or motion sickness that is concurrent with headache activity, you ask them, so how often do you get headaches? And they say, well, only about 3 times a month. And is that a lifetime pattern? He says, no, actually I started getting headaches about a year ago. And when did this dizziness problem start? Says, well, about a year ago. And but do the headaches and the dizziness ever occur at the same time? It says, well, no. But in the back of your mind, you're thinking they don't have vestibular neuronitis, they don't have BPPV, they don't have Meniere's disease, they don't have a superior canal dehiscence, they don't have anything other exotic, they don't have acetazolamide responsive vestibular cerebellar syndrome. They probably have migraine. Let's just stay in the common category, okay? Let's not like bypass that, and you can usually help these people. So, and the other thing is that there is a correlation with sinus symptoms in these patients. A lot of because we're interested in dizziness, we don't ask them about the sinus symptoms. The neurologists are really not interested in sinus symptoms, so none of the criteria include sinus headache. But if they did, that would be another inclusion criteria for migraine headache or vestibular migraine even. Where do these patients usually go? Primary care. Patients with migraine headache go to primary care, and the neurologists are the recognized specialty care providers for migraine, but only about 16% of migraine sufferers ever see a neurologist. We are what Jean-Paul Sartre referred so disdainfully as the others, and we're intruding. We need to start treating migraine. We step on other people's territory, respectfully, but in the service of our patients. So we did a nice epidemiologic study in 14 clinics. We randomized about 1,500 patients, and with just routine otolaryngology patients to see how much migraine there was. And we used the same migraine assessment tool, MAT, that was used in the largest epidemiologic study in the US that gave us the 13% number. And we found that we have in the otolaryngology office, about a 16% incidence of migraine, IHS migraine headache walking in the door. Now that itself was significant, but you would expect patients who are so sensitive to complain more, maybe to go to the doctor more. What was interesting is that so many of them have chronic migraine. Now, what does chronic migraine mean? That means they're having headache activity more than 14 days a month. And so that was really just a subset, because chronic migraine is only about 0.5%, but it's about 5% in ENT practice. So there's something about the symptoms that patients get that drives them to the ENT office. And they don't always have headache symptoms that are going to drive them to the neurologist, so they come to us instead. And when we measured their headache activity with the dizziness handicap inventory, but we also measured their sinonasal symptoms, and there was a direct correlation between the severity of their dizziness and the severity of their sinonasal symptoms. So if you had more severe dizziness, you would have more severe sinonasal symptoms, and less and less. So specifically, only 18% of these patients had no complaints of dizziness of any form. And what they did complain of was lightheadedness, unsteadiness, spinning, feeling displaced in space, or rocking and swaying, almost a quarter of them. So what do we do about it? How do we treat these patients? First, it's really tough if you have a patient who is right away saying, I don't have migraine, I know what migraine is, and I think this is really just too far out for me to get my head around. You have to get them to buy in, and I think the most effective way to do this is just to say, yeah, I know you've heard of migraine headache, and we've all heard of that, but there are many other manifestations of migraine that as a physician I know about and see, but that you've not heard of. And the headache, believe it or not, the headache doesn't even need to be there for migraine. Migraine headache is just one kind of migraine, but you have another kind. And I tell them, I say, have you ever heard or had of an ocular migraine? And when they do, I say, well, when you have an ocular migraine, there's nothing happening in the eye, fortunately. It's happening in the visual processing areas of the brain. Well, the same thing can happen with dizziness. And so although the ear can sometimes be involved, most of the time it's the processing of the balance information which is distorted and can cause these symptoms. But we can use the same kinds of medicines we discovered worked for migraine headache prevention to cure your symptoms. And that is usually a pretty good enrollment spiel. But a spiel it is, so practice. I give them a handout and I give them homework because that's a part of enrolling them. I have on my website, if you Google Teixeira patient information, I have a lot of information there that I have put in English and in Spanish and as PDFs that doesn't have my name on it. So you can use that in your clinics. And that explains to them this more than a headache identity of migraine. And I have a YouTube channel, Michael Teixeira MD, and I have them listen to an interview about vestibular migraine and anything else they want to listen to. I say, I want you to listen to this on the way home. There's nothing to watch. It's just the recording of an interview, and you'll recognize the symptoms that you have. But believe me, you don't have all the symptoms of vestibular migraine. You'll be glad when you listen to this that you don't. And they go, and then they feel enrolled, because what getting enrolled involves is being willing to go through some trial and error. Basically, we want them, if there's an obvious trigger like stress or sleep, for something is preventing them from getting rest and they're only sleeping a few hours a night, well, that's the obvious trigger. So let's see if we can remedy that. But I explained to them that medications are there to elevate the threshold, so we have less frequent and less severe threshold breakthrough. And then if we still have episodes, we'll have to have a strategy for managing the breakthrough events. And to find the medications that are going to work for this requires trial and error, because we don't know what each individual's genetic susceptibility might be. It's helpful if there's someone who is under treatment in the family, because if they're responding to a sodium channel blocker, well, we'll start with a sodium channel blocker for them as well. Otherwise, we have to make some decisions. So education and teamwork is really important. If they do have triggers they can identify, or they have really poor lifestyle hygiene, that's one way to manage a lot of these triggers, just to rest. Migraine hates regular and boring, same bedtime, regular exercise, good hydration, always eating at the same time, that sort of thing. Migraine hates that. So most of these patients have chronic symptoms, and so preventive therapy is needed. And sometimes they'll have such infrequent big attacks, but no symptoms in between, that they're unwilling, and it seems and it would indeed be unreasonable to treat them every day. So those patients, we give them steroids and promethazine, and we can reduce on the day one, and often we can reduce their 3 or 4 day twice yearly attack to a 1 day episode. That's an amount of disability they can live with. In some cases, PT can be available, but you need to have a sensitivity to whether they have a concurrent vestibular weakness that's uncompensated, concurrent BPPV whose resolution can be helpful, and understand their tolerance for the dose of therapy. It may, I mean, you're in a bad position, you can get in a bad position in a couple of ways. One, a physician sends you a patient as a PT, and you see them and you have a course of therapy, you see them 2 or 3 times, and you find out that every time they see you, they go home and they have like one of the worst evenings of their life because you've provoked their symptoms the way the VNG did. And it may be that the dose of therapy that they will tolerate is 6 minutes, even though you have an appointment that is 45 minutes or an hour. And you perhaps need to modify your strategy. Is there something that they can do productively for 6 minutes several times a day on their own? The other conundrum and problem you find yourself in is that you know the diagnosis and the referring doctor doesn't, and you realize that you're not getting very far. That is a tough situation. And so what you have to do is give patient education materials when you're quite certain, so that they can become aware of how well they align with this diagnosis, and take that back to their physician and allow that physician to direct them to someone who can really solve the problem. Because you're not going to be very popular if they see you and then they never see that physician again and again. So, for headaches, we sometimes break cycles with Botox or nerve blocks if they're continuous headaches. So, vestibular therapy has had some mixed results, but many patients can benefit when it is managed. And one of the things that you can do is educate patients and be one of their advocates, and also prevent them from avoiding movement and you remember, these patients can also transform into PPPD. And we need to keep them moving, keep the attitude right. Focusing too much on being hypervigilant is not constructive. So here is a patient, a typical patient with breakthrough, and we give medication. Now they have fewer episodes and less severe symptoms. And then we clean up the diet, so they don't eat a whole bag of Doritos every Sunday. They watch football and no hot dogs and imagine what kids eat. If you're a migraineur and you eat yogurt all the time and peanut butter all the time and bananas all the time and chocolate almost every day, then those are just and hot dogs, those are things that can really push you over the top. Then you manage the physiologic triggers that you have control over just by improving lifestyle. The environmental we have very little control over. Then you add medication, and now you have a well-controlled migraine sufferer. Whether they have migraine headache or vestibular migraine, they're going to be much more capable and happy. So we have them keep a diary, not a complicated one, just on a checkbook calendar, which we give them. And I say keep it by your bed. At the end of the day, I want to know if you had a headache, and I want to know if you had dizziness. And use a scale of 1 to 5 or 1 to 10, and just all I want to know is how high the needle went that day. Even if it was for a few minutes or a few hours, it doesn't matter. And over time, this will allow you to avoid a very painful interrogation when they come back having tried a medicine and trying to figure out whether they're really getting better from it. Because you can see that you say, wow, since you were here last, you have like 15 days with nothing on it. And you used to have no days. So that's actually an improvement. And then the other days, it looks like you never had 1s and 2s, but now Now you have a lot of 1s and 2s in your intensity. And that helps you to make good decisions about whether to adjust the dose of a medicine or to change a medication altogether. So often we just have to dive in and there's no test. There's no test that tells us this is vestibular migraine. We have to use medication for hypothesis testing. So we have the hypothesis, pretty strong one, because we recognize the migraine pattern of disease. And then we make a list of medicines right there in front of the patient. This is what I do I say we're going to make a list of 5 different medicines, and there are basically 5 categories. And they say, you're going to give me all that medicine? It says, no, we're just making a plan. And you and I are going to execute that plan. We are not going to spend 2 years doing this. You have suffered enough. We want to find out in the next 4 or 5 months what works for you, and we'll then adjust the dose and get you really under control. And they're all in at that point. So, but what I tell them is that I can't see you every 3 weeks to make these adjustments. I'm going to see you every 2 months. But if you're on a medicine and you discover in 5 days that you can't tolerate it, then you call and say, I'm ready for plan B. I couldn't tolerate the nortriptyline, perhaps. And we just send in plan B. And if you're on a medicine for a month and you can't tell the difference, or you have to think about whether you're any better, then it's not working well enough. We're not going to waste more time. Call and say, I took it for a month. I can't tell the difference. I'm ready for plan B. And we move down through A, B, C, D, and E, and usually we get some response, and we latch on to something that's working for them. So the optimum treatment of vestibular migraine, remember we have the vestibular nuclei here, and we have this interplay between the trigeminal nucleus and the vestibular nucleus, the dorsal raphe, the locus ceruleus, the reticular formation. And this is all a part of the typical migraine headache syndrome, and we want to treat that, right? And that will decrease migraine headache, but it may decrease some abnormal functioning in the vestibular nuclei. But we can't forget that vestibular symptoms many times are what we do have awareness of is this interaction between the cerebellar vermis. We were talking about the cerebellar vermis today, and this is the cerebellum, and this is the vermis going down the middle, and this is the nodulus, and this is the uvula of the cerebellum. This is where the main inhibitory connections between the cerebellum and the vestibular nuclei ride, and these are GABAergic inhibitory fibers. This puts the brakes on when you have an acute vestibular event. That's the cerebellar clamp. So then we also want to enhance that cerebellar inhibition by using GABAergic medications. And this is the reason that sometimes benzodiazepines, which are GABAergic, can be an effective companion therapy. They directly decrease some of the symptoms in these patients. They can also modulate some of the out-of-control anxiety that they're feeling and maybe prevent them from, give them a sense of control and prevent them from sliding down the sliding board into the PPPD pit. So what do we use? We use, remember, calcium. Remember, we were focused on ion channelopathies. Well, we use beta blockers, calcium channel blockers, tricyclic antidepressants. We use SNRIs, in particular venlafaxine, and anticonvulsants, the sodium channel blockers. And sometimes we use carbonic anhydrase inhibitors. So, as I mentioned, if someone in the family is already there, we follow the lead because they may have broken trail for your patient. And sometimes you're there, and the patient. Another way to enroll patients is that, do you have any children? Do they have migraine? Well, let's find out what's going to work for them when they get into this situation. And a lot of mothers, they say, okay, I'm in. So nortriptyline is probably the single most effective medication that we use. It was a terrible antidepressant. It's made from an antihistamine. It was in the late 50s and 60s. It was used for major depression at doses of 100 to 250 milligrams. And it works. It's a serotonin and norepinephrine reuptake inhibitor, SNRI, but it is also a medium potency sodium and calcium channel blocker. And it's also anticholinergic, which is really good because it can offset some of that parasympathetic outflow that so many of these patients have as a part of their symptom complex. It also is a mild soporific. So you take it before bed. It doesn't put anyone to sleep, but it does relax them, so sleep comes a little easier. And instead of the problem with it was that at these high doses, you had the side effects of sodium channel blockers and calcium channel blockers and anticholinergics and serotonin medications, all at the same time in one evil medication. But at low doses, it seems to be pretty good. So we give 10 milligram and for a week to put the toe in the water, and then we go up to 20 milligrams. And and about half of our patients take 20 milligrams. Another 30% take up to 50 milligrams, and a few take 75 milligrams. And I have a handful of patients. On one hand, I can count the people who take more than 100. Even at low doses, some people will feel a dry mouth from the anticholinergic effect. And if they get too dried out, they can get constipated. So I have them buy a bottle, if they do have that, of magnesium citrate. Magnesium is good for migraine too. And a lot of people want to try that first, but I hate to get into a period where you're trying for months on natural things, and I have this idea that the symptoms get more durable. You know, the brain is plastic. I literally tell the patient sometimes, says, we're sending your brain, which is misbehaving badly, to reform school. There is no weekend program for your brain. This is going to take at least a couple of semesters. And if you behave really well and you're doing really well on the medication, this isn't forever. But if you're doing really well, and so well that you're asking the very reasonable question, I wonder if I still need this medication, well, then we can back it off incrementally, see if the coast is clear, and continue with that. So, you know, it's not a sentence for them, and that's important for them to know. So about 1 out of 6 patients feels that they are a little slow in the morning for an hour or two, and I just have them take it an hour or two earlier in the evening, if that's the case. And a rare patient, 1 out of 50, says, I can't sleep when I take it because the norepinephrine effect is too great for them. And then I say, take it in the morning, and it'll be like a cup of coffee for you. So and people can be unusually sensitive. If it works, but it's just too many side effects, then we switch to amitriptyline, which is a tablet, not a capsule, similar, and they can take 5 milligrams if they need to. So if I usually start with nortriptyline, unless there's a strong contraindication, in most patients who are over 50. That's my personal preference. There's no best recommendation from any organization. That's just what my habit has been. Patients who are younger than 50 they feel like, I don't know, I just feel a little tired. It feels like they lose a little bit of their mojo. After 50, you kind of lost it, and you don't notice it anymore. And so you just, it's a good place to start. But it will be 3rd or 4th on the list for most patients who are younger. But anyway, that's where I see it for the older patients, older than 50, male or female. Now, topiramate is very effective, and I tell patients that, well, topiramate is very useful. It's an anticonvulsant. and a carbonic anhydrase inhibitor. It has a really good evidence, but it got a really bad name because when it was released, the manufacturer made 50 milligram tablets and said, start patients at 50 milligrams twice a day. And a lot of patients ran into the wall with side effects. Now we use 25 milligrams and we ramp up weekly to 50 milligrams twice a day, which in my mind is an index dose. If you don't respond at 50 milligrams twice a day, you're probably not going to respond no matter how high we go. If a patient has ever had a kidney stone and it was a calcium carbonate stone, then this would make them a super stone former, and you would only do that to an enemy. And everyone gets a little numbness and tingling in the fingers and toes, but that goes away in a few weeks if you stay at the same dose. The cognitive effects can be limiting, but I don't focus people's attention on the possibility of cognitive effects. They're already muddled. And most of the time, it's more often that they feel better and they get their head back when their migraine activity and vestibular migraine is controlled. But I run into people again and again, and they say, I always lose people when I tell them about the cognitive effects. Well, you don't have to tell them that. You just take the medication, and if they tolerate it, that's great. And if they have cognitive effects, it's not workable. You move on. Or you can use a long-acting medication. So it used to be that you could, about half the time, even when people have cognitive effects, we use a long-acting version of it. And this was something that was exotically expensive. No one would pay for it, and there was even after you did the right paperwork. And the idea is that once-a-day dosing, and it prevented the medication from peaking very high above the level that it needed to be. And because that high peak is the side effects. But then that peak falls off to below efficacy, to below therapeutic, and then they have breakthrough symptoms. The long-acting just rides right above their therapeutic level, so they have minimum side effect and minimum breakthrough symptoms at the same dose, or a lower dose. So that's a really useful thing, and it finally went generic about 2 years ago. So you can get the XR version of the topiramate if you need to. So, and it also decreases your appetite. The patients who are addicted to LaCroix water and things like that, the bubbles taste terrible when you take a carbonic anhydrase inhibitor, and they'll have to live with that. So a lot of people, a lot of young women we meet, that is very attractive that they could lose weight. So we that's a good medication. Beta blockers I use a lot, and young men tend to respond to this. It does limit cardiac output, so if they're really competitive athletes, if they have a coach, they probably wouldn't want to be taking this. But if they just exercise for fun, that wouldn't make that much difference. I use doses of 60 to 120 milligrams, rarely higher, but you can. I've only had a couple of patients over time whose depression was really noticeably worsened. Usually they lighten up when their symptoms get better. What I found is that a lot of patients already take metoprolol because they have AFib or flutter, and they I just switch them. It's a milligram per milligram equivalent dose. So if they're taking metoprolol 25 milligrams twice a day, I said, I'm going to switch you to 60 milligrams XR. The CNS penetration of propranolol is so good that often they respond, and they say, well, God, they didn't have to take an extra medicine, but their problem is solved. That's been really, really effective. This is even, beta blockers have even been used to abort episodes, and even some episodes of vestibular migraine as an eye drop. When you give it as an eye drop, it doesn't get processed through the GI system. It gets in the blood system, in the blood very quickly, and has been used as an abortive. Then calcium channel blockers. We have I use diltiazem. I think traditionally verapamil is used. Even patients who have been around and they've tried a lot of stuff, I always find out what they've already tried. They almost never have tried a calcium channel blocker. And then I put them on the cardizem. It is probably the best tolerated of all the preventive medications that we use. You can have a little constipation, and it's well tolerated as a first line or a second line. So topiramate for the young women, propranolol for the young men, tricyclics for the middle-aged people. That middle age is now 50 to 100. And then calcium channel blockers as a second line for anyone, but all four for everyone, because you have to run the list. I say, we just don't know what's going to work for you. You know, maybe 10 or 15 years from now, I'll use a cheek swab and put it in a hole in the wall, and it'll tell me what medication is going to work for you, but we don't have that, so we're doing some trial and error. So, and then venlafaxine is also particularly effective in some of these patients, and I generally go up it's a 37.5 milligram tablet, and I go up every week or 2 weeks to see to find their tolerance and efficacy. And clonazepam is also something that I don't hesitate to prescribe to get people out of their rut. When I can detect that anxiety and I can't get them immediately to someone to manage, clonazepam controls their symptoms and lets them regain a sense of control and stops the escalation, and then they can come back out of it. We're gonna just, let's see, now we use CGRP medications. There are now, in the last few years, medications which block the CGRP receptors or the CGRP molecule itself. These were biologics that were injectable, but now we have 3 oral options, and these can be great. And they are so effective for migraine headache that the drug companies are starting to pay for them as first line, but sometimes they require that you have failed numerous other classes of medication before they will approve it. So they're a little impractical to use unless you get samples in your office, and because you don't want to go through the paperwork of getting it for the patient unless they've already tried it and know that they're getting some response. That's a long talk, but in summary, vestibular migraine is really common. We have certain defined neurovascular mechanisms that are responsible for symptom generation in migraine headache. The CNS is globally affected by migraine in different patterns in different individuals that account for the variable and atypical presentations of vestibular migraine. And otolaryngologists, and all of us should be able to recognize it. Otolaryngologists should be prepared to treat it. If you need more education, we've put together a course, 6.5 hours of free CME. This was put together by otolaryngologists, for otolaryngologists. Over 5,000 people have done it, but most of them not ENT doctors, but the free was a good feature. There is a Migraine and Otolaryngology Society, which we invite you to attend, and we'll, in a few years, have meetings like this for otolaryngologists who really want to learn about migraine management. You can also, if you really want to get hands-on with how the decision-making happens in the clinic, then you could come for a couple days in Wilmington, Delaware, and we are training PAs and nurse practitioners. It's free in Delaware. And can we advance this way? And so we have a formal through the Association of Migraine Disorders, which we founded 13 years ago, a migraine apprenticeship program for APPs to improve migraine management. And you apply, and there are 5 clinical sites right now in the Northeast and in the West, and in I think in Colorado. Obviously, we have there's 5 clinical sites around the country, and we've trained about 15 so far, and we hope to train hundreds. Because this is one way that we can get migraine management into the otolaryngology clinics without waiting for an entire generational change and turnover. So I thank you. I hope this is what it's going to be like for you talking to these patients in the future. Sure. Okay, the first question is, have we studied the influence on the drop of estrogen levels in women with vestibular migraine in perimenopause and menopause? Well, the hormonal effects on migraine have been, we've been aware of that for a long time. The absolute effects are not well understood. I think that we have some emerging insight, but it's not. But there's nothing that's going to change. Are people here doing hormone replacement or recommending that, or having your patients go to discuss that? I haven't, and I think that's interesting. It's clearly a phenomena that's behind it, but the issue of doing hormone replacement to try to get rid of persistent migraine after menopause, that appears after menopause, is an issue that carries risk, an oncologic risk, and most patients probably should stay away from that unless it's better for them in other ways as well. The next question, elevator pitch to explain this to patients when they say they do not have headache. Most believe that migraine has to be associated with headache. And I think I did go over a good pitch for that in our talk. I just kind of pull rank on them. I say, I know. It says, if people who have real IHS migraine, they don't even need to see a doctor. They could talk to the teenagers at the piercing pagoda in the mall and get a diagnosis. They'd say, yep, that's migraine, all right, yeah. And vestibular migraine or atypical or form-fruste migraine equivalents require a little bit of awareness of associated aggravating factors. And so we just tell them that this is what it is, and I have a way to make you better. And if you team up with me, do a little education, and we're going to figure out what works for you and get you out of this rut. That's usually enough enrollment. Have I ever seen severe debilitating tinnitus be a co-complaint with vestibular migraine? Absolutely. I mean, there is actually an incredible interplay of the trigeminal nerve with auditory processing. And migraine, just as we have seen with PPPD, that some patients with a unilateral vestibular loss recover, and others, for some reason, don't recover and get lost in the world of PPPD, even though their compensation happened. We have patients, we can have patients with identical hearing loss, and one of them gets tinnitus and the other one doesn't. And what I do is I screen patients by asking tinnitus patients, does your tinnitus ever change intensity or character? And most will say, well, yes, it's really loud in the bedroom. Well, of course, because it's quiet in the bedroom. But if they say, well, yeah, some days it's really loud, it really bothers me, or I'll go for a period that it's loud, or I get these crescendos a couple of times a week, well, that's not going on in their ear. That's going on with the levels of arousal in the central nervous system. And those patients do respond to migraine management. We have lots of sounds, even pulsatile tinnitus can be from migraine. We had a big discussion about what the way we perceive things and that are inside our body and part of our volitional movements, and the difference in the way we perceive them when they're happening to us. Well, that's called exafference or reafference. we have lots of internal sounds that we don't hear because we have auditory systems that cancel internal sounds that would otherwise drive us crazy. And patients with migraine, those trigeminal systems actually are dysfunctional, and we calm down that dysfunction, and their pulsatile tinnitus goes away, their tinnitus reduces or goes away. You can look at my website. I have a 1-hour presentation on this topic with about 15 patient interviews who describe their tinnitus in relation to their migraine treatment. So thanks for that question. Any research showing correlation between pelvic floor dysfunction and migraines? Migraine and pelvic floor are linked to TMJ and with higher incidence of migraine in women. Absolutely. I think that we're slowed. It's interesting that OB-GYN are the patients who see are the physicians who see these patients. Autonomic changes that can be are prevalent in migraine and are involved in pelvic floor dysfunction, but are generally ignored by obstetricians. They will treat, most obstetricians will treat migraine in their patients with triptans, abortive medications, but they don't really attend to this. And I think that that's an area for the future, for increased awareness. 1 or 2 more questions. Have I seen a trend of BPP recurrence with extreme changes in weather and barometric pressure? Not specifically, but certainly with migraine headache, as we described. There is evidence to support resistance to training to decrease inflammation for migraine, vestibular migraine prevention, full body resistance training, and cardio. Thoughts on this for PT? Well, it sounds to me, for most patients with migraine, especially chronic migraine, a day they exercise is a better day. Some patients have exercise-induced migraine, but that's a minority compared to the patients for whom exercise is a healthy activity, perhaps endorphin release. It's easy to come up with simple ideas, but the actual mechanisms are probably complex. And are there questionnaires to help with differential diagnosis? I would say this will be the last question. And I would say that the most effective way to deal with the differential diagnosis is with this material that I have tried to prepare for you for exactly that purpose. It's William Osler famously said, "Listen to your patients. They are telling you their diagnosis." And here we are. We'll end with that. Thank you very much for your attention.